I'm going to like to introduce our moderator. He's got a very long history of executive and board leadership in the healthcare insurance space. Currently, he serves as the president and CEO of First Care Health Plans located here in Austin and provides insurance through the state of Texas. In addition, besides that, he's a director of the Texas Association of Community-Based Healthcare Plans, as well as the Texas Association on Health Plans. He's also a board member on the board of directors here of our NACD TriCities chapter, and someone I've had the extreme pleasure of getting to know very well over the last 3 years. So I'd like all of you to welcome Darnell Deck. Darnell? You're going to take it from here, right?
All right, Rick, thank you very much. So I'm very excited about this program, mainly because we've been talking about getting healthcare on the docket for a program. And while we've done it on a national basis, we haven't really done much here in Austin. So this is a special treat for me. So let me introduce the members of the panel. We'll start with Craig Cardola. Craig is the president and CEO of Ascension, Texas. He's also a senior vice president at the health system level. He joined Ascension in September of 2017, where he has a number of functions there. He previously served as a senior vice president at Memorial Hermann, and in fact, Craig had several roles while he was there, including chief executive officer of the Children's Memorial Hermann Hospital. He also has served a role as the chair of the advisory board for the University of Texas Health Science Center at Houston's George McMillan Fleming Center for Healthcare Management. He's also served on boards at Children at Risk, National Association of Children's Hospitals and Related Institutions. He is an honor graduate from the University of Texas here at Austin with a degree in psychology, and he also has continued his studies at the University of Houston Clear Lake, where he's earned dual degrees with Master of Healthcare Administration and Master of Business Administration. Craig and his wife, Allison, have 2 children, and they live in the Austin area. So Craig, you want to join us up?
Sure, thanks.
All right, next up will be Kathy Eddy. Kathy Eddy is the founder of Health Plan Alliance. She was also the former director of Presbyterian Health Plan and Health First Board of Trustees. Kathy, in her former role, because she just retired just a few days ago at the end of April, from her role as the president and CEO of the Health Plan Alliance. It is an organization founded for the purpose of supporting provider-sponsored health plans, and you'll hear more about that in its membership. Health Plan Alliance has over 50 health plan members and is located throughout the country. That was when I actually met Kathy several years ago. She's previously served as a vice president of clinical affairs for VHA, and she's been an advisor to the Health Technology Center in San Francisco on business modeling and marketing. Kathy received her MBA in healthcare management and insurance from Wharton School at the University of Pennsylvania in 1992, and she has initiated a mentor program for healthcare management graduate students that has continued for the last 25 years. So let's welcome Kathy. Kathy. Last but not least is John Hawkins. John Hawkins is the Senior Vice President of Government Relations for the Texas Hospital Association, where he is responsible for managing all aspects of the THA state and federal advocacy efforts before the legislature and regulatory agency. He is a senior policy analyst He has served as a senior policy analyst for the Texas Sunset Commission. He's also served as legislative aide in the House of Representatives for 2 legislative sessions, and has worked as the legislative liaison for the Texas Department of Information Resources for 3 sessions. He's a native of Tyler. He has a Bachelor's of Arts degree in government and Master of Public Affairs degree, both from the University of Texas at Austin. So please welcome John. All right. As you know, there have been a ton of changes in healthcare, and there have been a lot of massive shifts in the healthcare space. And some of those things have been driven by political events, such as the Affordable Care Act, better known as Obamacare. And there have been a lot of arm wrestling over whether that program will actually continue. There have been big changes on the technological front, and there are a lot of changes that related to not only those advances in robotics and a number of other things. You may have even heard about precision medicine and all of the activities going in that area. Big data analytics is also one of the big push and drivers behind a number of the changes. And the other area that we will explore is about all the market consolidations and all the changes. And just one data point, and we'll come back to this, is that in 2017, there were 115 different transactions just in the healthcare space where there were a number of systems that were merging and doing a number of deals. Already in the first quarter, there have been 30 such transactions, and we're already on pace of actually exceeding the number of deals and transactions and consolidations and changes that are taking place. So it is, this topic is very ripe for us to discuss because it really talks about the fact that in healthcare, we are definitely having those changes that are disruptive and often with different emphasis. So this is one ripe for our discussion. So let's get the panel involved, and we'll start right from the top. And just a few months ago, all of you have heard and maybe even taken a closer insight into the announcement that Amazon teamed up with 2 other powerhouses, Berkshire Hathaway and JP Morgan, to form a healthcare company. There have been a lot of speculation on what they're going to do, but their stated purpose is the fact that they will disrupt healthcare. How they will do it and ultimately and what the product will be is yet to be seen. You may have read in the newspapers about more currently Walmart and Humana teaming up, and that we see taking place right on the heels of the Aetna CVS. So there's some different bedfellows in this overall process. And at the beginning of the year, United Healthcare bought DaVita Medical Group for like $5 billion. And DaVita is a series of renal type services that they provide that has created yet another process of integration with these plans. So I want to go to our panel, and this will be general, and so I'll look to you guys to chime in. With the continued vertical integrations, mergers and acquisitions, and big tech companies making healthcare moves, it is clear the pace of disruption in healthcare is accelerating. But what does this mean for the future of healthcare? Craig, you want to get us kicked off?
Happy to. I have a lot of comments around this one, actually. So it's interesting. I think you have to understand a little bit about how healthcare is kind of woven together. And I think sometimes we forget that largely, and certainly in Texas, that on the physician practice side, it's really a cottage industry. I mean, you have a lot of physicians that are running their own practices, which are small businesses. So there's a lack of continuity and a lack of cohesiveness there. And you have independent hospitals and large health systems. I represent Ascension, Texas, which is about 200 locations between Austin and Waco. And so you have these big health systems and hospitals, and then a lot of independent physician practices. So it creates disparity, it creates lack of continuity, access issues, sometimes conflict between the physicians as well as hospitals. And I think many times the consumer, the patient, is left in the middle. And I think one of the things that's changed dramatically over the course of the past few years, obviously, is increased technology. And I think everybody probably has an iPhone or some element of that device. And so access is being crammed now into devices so that it is much easier to find healthcare. I'm intrigued as an example. I'm not on Facebook, but my wife is. I often say I poach my wife's Facebook account. And she will, inevitably, there'll be some mom group, and they will post a picture of some kid who has a rash or a bite or whatever, and they're crowdsourcing diagnosis and treatment because it's quicker than trying to figure out how to get into their pediatrician. And so we're seeing, I think, consumerism getting smashed together with relatively archaic health system because the consumers are demanding it. And at the same time, health systems like ours are under incredible cost pressures. And so you have now these mergers, which we can talk about as well, but you have new entrants into healthcare that are taking away profitable business from health systems. And mind you, for us, if we had a 5% margin, that's a really strong year in not-for-profit healthcare. So we're talking about relatively small margin because of the drive towards more of a consumer-centric focus. So it's forcing organizations like ours to have to rethink our healthcare delivery. And in many cases right now, the economic reimbursement model doesn't support some of the things that we need to do, whether it's legislative or legal or regulatory. And so that conflict is also going on behind the scenes. And I'll just end with this, that it is the disruption that's taking place is uncomfortable for sure. But it's going to require significant and I think bold leadership to move organizations forward into the future, to be open and thoughtful about healthcare delivery so that we can do what we are designed to do, which is care for patients and families.
Okay. Kathy?
Yeah, one of the common traits that you mentioned about some of the new entrants is they're in retail and they're in consumerism. And I think those two combinations about how you've seen the consumerism trends play out in Amazon and other stores, that healthcare's kind of been behind in that aspect of it. There was a survey recently where they asked how many people would buy health insurance from Amazon, and 35% said they would, and Amazon doesn't sell health insurance. So, but they're used to buying everything else off of Amazon, so it's an easy transition. If you look at Walmart, there's a huge amount of the population that is through those stores all the time and that retail traffic, and so they've been looking at how do they expand their footprint in healthcare and what are they offering. And then some of these big box stores, whether it's the pharmacy chains like the CVS or Walmart, they're trying to compete against Amazon. And so they're trying to figure out how do we best use the bricks and mortar that we have. And so that whole primary care and people flowing through there is going to make, I think, a big difference. And that creates a challenge for the traditional delivery system. And the consumer, they're looking for convenience. And especially the millennials, they don't necessarily want to go to a doctor's office if they can get it done, virtually. And so I think virtual care is going to be a big trend going forward.
Well, and Amazon's done a great job in reducing friction. If you really think about why they're successful, they've reduced a lot of the friction points around buying stuff.
Sure.
So if they can find a way to translate that into healthcare and reduce the friction of access, that's a big game changer.
John, do you have a...
Well, I would say, to build on what Craig said, one of the challenges is just the legal and regulatory environment, and really that's the space that I work in. And you've got to look at really a system that is driven by and large by our federal Medicare system, which was a fee-for-service system. So, the more you did, the more you got paid. And that's not necessarily good for outcomes. It's not necessarily good for cost containment. So, Craig mentioned we've built this system that's focused on these institutions that are engineered for delivering care really on their terms, not on the consumer's terms. And so you see a lot of frustration trying to re-engineer that system when the regulatory scheme doesn't necessarily deal very well with that. And then when you try to make a change to that in this political environment, something that is that large and has so many different moving pieces, really you've seen this press with what's going on with these redistricting cases. One of the problems is we have created more, we've moved kind of that middle out of our legislative bodies, and that was the group, the moderates on both sides, that had to come together and do really hard things like healthcare reform, because that's basically asking everyone to give something up for the greater good, and we don't really have the ability to do that anymore. So it's easy for someone to take, one little piece out of this and say, this is not going to work, and kind of jettison the whole thing. But really the reality is, all of this is driven by cost. Like Craig said, companies can no longer afford to continue to spend more money on healthcare. Individuals can't, and state and federal government can't either. I mean, the whole discussion about entitlement reform, the fact that we're putting 10,000 people a day on a Medicare, a system that the average couple pays in $185,000 in benefits and uses $350,000 in medical care. That is not sustainable over the long term. And we were talking earlier down the street at the Capitol. Every dollar the legislature puts up for the Medicaid program is a dollar it can't spend on roads, prisons, and public schools. So that's a political issue.
Darnell, can I give a backdrop on the
Sure.
federal side a little bit to tie into John's comment? So, the total spend on healthcare for the U.S. government right now is 17% of our total GDP. Almost over $3 trillion. I mean, it's totally unsustainable. And so that is partly why you have all these other companies running into that, because it's a $3.3 trillion industry. So that's one driver. And then on the flip side is what John said, the current spend on Medicare alone, with 10,000 people coming into Medicare each day, and about 60% of my payer is either federal or state. It's either Medicare or Medicaid. So it's bankrupting states, it's bankrupting the federal government. They're looking at this and saying it is completely unsustainable. Help us find a way to deliver cost at a lower price point. And so all of that stuff right now is kind of the collision point in our country that's creating disruptors, it's creating opportunity, it's creating uncomfortableness on our side, bankruptcies in some cases, because of those two collision points. And I think a lot of it's going to rest with, can we get elected officials to come together on the moderate side to create a new model for us to be able to deliver healthcare?
The thing is, you mentioned collision point. The fact that we have some odd matchings, or would appear to be odd matchings. Just recently, there's been talk about Uber and Lyft partnering with some of the larger health insurance companies. And you ask, why would that take place? Well, transportation, to get patients from A to Z, and to make sure that they get to their appointments and things like that. But if we could take that for a minute, talking about this crash point, 5 years out, I was going to say 5 to 10, but 5 years out,
Yep.
with all of these things coming together, converging, what do you think the healthcare landscape may look like?
A couple of points. Interesting stat, where Uber and Lyft have entered markets, they've seen a 15% reduction in ambulance calls, because more families are able to access Uber and Lyft versus an ambulance ride. So just kind of an interesting element. I think there's amazing amount of data in AI, artificial intelligence, that's going to force a different look on the clinical side of healthcare. One quick comment on that, there was a study that just got published earlier in the year in Nature, which is a very good, legitimate publication. But they had 21 board-certified dermatologists compared with a algorithm that was prepared by a computer scientist that had 130,000 images of different skin lesions. And the AI skin lesion tool equally outperformed the 21 board-certified dermatologists, right? And that was done by a computer programmer. So there's going to be a lot more of that coming, which I think will change healthcare, the whole genomics and all that. So on the scientific side, it is rapidly accelerating, I think will change. On the healthcare delivery side, it is clear that we will have to figure out how to provide care at a lower cost point. Because right now, on a Medicare patient, on average, I get 85 cents of my cost back on that Medicare patient. And as I talked about, Medicare is continuing to increase, so every day that gets harder for me. So it will force us to have to find ways to both either reduce cost, constrict our footprint, and move more into the ambulatory space. And so I think the major thing that we're going to see changing is you're going to see a consolidation in Texas on the physician practice side, which is late to the game compared to a lot of other states for sure. And then you're going to see a move more towards outpatient imaging, outpatient surgery centers, outpatient services in total, because you can do that at a much cheaper price point compared to the fixed cost infrastructure of a hospital. So organizations like mine that are very hospital-centric have to rethink our asset portfolio of what we have and look more towards that outpatient and ambulatory space. So those are two, one on the clinical science side, and then I think the second that I gave is more on the delivery side.
I think to take it one step further, I would say that it's even moving out of the ambulatory into the home.
True.
So there's a lot
Very
of
true.
services that are moving there, rethinking who can give primary
Right.
care. So you already see these minute clinics and others. People go to them because it's quick, it's easy, and they can do the low-level aspect of it. Pharmacists are being used to give advice in that. There was one city that found that they could do much better with their diabetics because the pharmacist saw them monthly as opposed to getting in the physician's office. And if they needed to be redirected for that type of care, they would. But I think that rethinking of how things get delivered, and then caregivers are kind of the forgotten piece of the equation because more people are taking care of elderly patients and others, and how can they become more involved in providing care and understanding what's being delivered.
So Kathy, you've spent a lot of time with health plans, and you've also worked with health systems. At one time, we had the Pac-Man effect, where health insurance companies were buying other health insurance companies, or buying business or consolidating with. And then probably 25, 30 years ago, we started to see the growth of what we call these provider-sponsored plans, where these health systems created their own insurance companies. And so we've had that proliferation. And now what we're seeing with the Uniteds moving out and Aetna, different matches, what do you think is the future of the local, regional health plans in the play? Do you see a role?
Well, they were started in different phases. So the ones that were started in the 80s were what I call during diversification strategy. They were starting up laundries and pharmacies and health plans. And those early ones were also meant to help the health systems fill their beds. And that kind of flipped around. In the 90s, the plans that got started that were part of integrated systems, everybody thought they had to have one to be the integrated system for the Clinton healthcare reform that didn't happen. And so a lot of those plans got sold off or closed down. The ones that have started up in the last 5 years or so, it's really health systems wanting to take on more risk and move up and take the first dollar and figure out how to do it. So with Medicare, people used to be primarily in fee-for-service, and now I think it's 1 out of 3, and they're expecting it to be closer to 1 out of 2 is the boomers age into it. They're in Medicare Advantage plans. And so when you're in that type of payment structure, we're taking risk. We're seeing a lot of providers that are moving into that as well. I think the biggest advantage for a health system who has either had a health plan or starting one is they're learning how to manage risk and manage populations. And if that's the way the payment methodology is going to be moving in the future, that's sort of their learning lab for doing that. And so there's kind of the big insurers are still out there, but they're trying to figure out how to partner with providers, which has not necessarily been in their DNA. They usually were beating up on them on price, and now they have to figure out how to work with them. I think for the integrated delivery systems, they're trying to figure out how to make all these parts work more closely together and to work through that.
Okay. And so, John, talking from a public policy standpoint, what are some of the political forces at play on the policy side that you see is having its biggest effect on healthcare?
Yeah, so beyond just the money issues, obviously we've got to manage the spend on the entitlement programs, Medicaid and Medicare, get that right. Beyond that, there's just a whole lot of regulation. When you talk about some of this clinical integration, we've got a lot of, I call them scope of practice issues. When you look at licensure, a lot of licensure, some folks call it, bottleneckers. What those practice acts really do is exclude other entrants into the market and really limit what, a physician or a pharmacist can do. And some of these integrated networks, you can use extenders like nurse practitioners and others under appropriate supervision, again, managing outcomes and looking at quality to actually increase quality and increase throughput. So I think we really need to look at really all those barriers to entry out there and make sure we're engineered correctly for that. I think there are a lot of issues with just the way we license facilities. One of the challenges we have from the Hospital Association's standpoint is the payment model is moving us to more of this outpatient setting, but we still do have Hurricane Harvey and mass casualty events. So trying to really thread that needle of making sure we still have level 1 trauma centers and we have infrastructure with backup power and all of those needs when you do have a disaster, but do that in a way that appropriately delivers the care in a lower cost setting. So those things are out there and I think are very important. And then just breaking down some of these old fee-for-service regulatory barriers, for example, the ability to share profit. If Craig goes to his physician group and says, if you use a cheaper implantable or whatever the example would be, let's share in that savings, you'd get thrown in jail for that.
That's right.
Right now. So the payment model is moving us to more of a value-based shared services model, but we still have a lot of regulation that doesn't allow us to do that. And the other thing they're doing, talking about the home care and nursing home care, now hospitals are being penalized for readmissions. So if you come back to a hospital for something that didn't go well, if you get a hospital-acquired infection, you get penalized for that. So again, I think all of those are really appropriate regulatory strategies that can help drive better quality of care.
So let me put you on the spot. The Affordable Care Act. How do you see that playing out?
Well, man, that's a tough one because again, it's just hard to do something that big up in DC right now. But obviously, the CMS is still going to move to pay for. They're going to still drive us toward pay for performance in the Medicare program. The private market providers are putting a lot of that regimen in place. So the market is taking care of a lot of these issues. But the biggest problem is you've got the EMTALA law, the Emergency Medical Treatment
Active Labor Act.
Active Labor Act, that was signed by Ronald Reagan actually in a Budget Reconciliation Act that created universal health care. Anyone can go to a hospital and at least get stabilized and get some level of treatment. So we created the community expectation that everybody is going to get care, but we've never figured out a way to finance that. And then there's just a myriad of insurance issues that if you're going to require to get everyone to get coverage, you have to deal with a lot of those adverse selection issues. So the financing piece is key, the coverage piece is key, and then just dealing with benefit. The thing I hear a lot from private employers is benefit design. I mean, benefit design is how you can drive consumerism and people having more skin in the game and making better decisions about their health care.
Darnell, can I make one comment just on the kind of the economic model of how healthcare works? So right now, this is a broad statement. I could certainly give you many other examples, but broadly speaking, we get paid on a fee-for-service model, which means if you show up in the doctor's office, the doctor gets paid. If they do surgery, doctor gets paid. You show up in our hospitals, that's how we get paid through imaging and CT and surgeries and procedures. And you can see that that's wrought with problems for overutilization, potentially. On the flip side of that would be what we refer to as population health, perhaps, or value-based payment, to where organizations like ours at Seton are then tasked with managing a defined population of patients, and then whatever I could do to keep that population healthy, because I'm already getting the dollars on the front end, kind of upstream, the better we perform. And the hard part for us is we're right now in the middle of this change on reimbursement methodology across the whole country because of all the other elements we talked about. And so right now, my best day is when our hospital's full. Under a full population health or value-based, my best day is when the entire hospital's empty. I mean, that is literally where we are today, and the current payment methodology isn't lined up yet to help pay for all of that other stuff that I just mentioned to keep our hospitals empty, because hard for me to partner with physicians to keep patients out of the hospital or do home health care or do telemedicine, because there's a lot of barriers right now around that. So that's, from a hospital administrator perspective, that is the challenge today and the conflict. And again, all of that to eke out a 3 to 5% margin on the hospital side.
And I guess to answer your question, until both sides come together and say this is going to bankrupt us as a country, right, unfortunately, we're going to have to get up to the cliff, I think, before we do something.
Health plans are going to solve it, right? Help us.
Yeah, we're going to push the risk back on you.
Yeah, exactly.
One of the things that in this whole change of administration, you heard for a lot of years about repeal and replace, and that didn't happen. And so in Washington, the ACA will be the platform going forward for what we're going to do with healthcare, but because so much of it was written of the secretary shall, that there's a lot of leeway in what that administrative person can do. So probably what you're going to see is a change in ideology and how they're going to revamp some of the things. So one of the initial things was eliminating the individual mandate. That was something they were able to do. So you're going to see some changes that are taking place in Washington now that repeal and replace didn't go through, but it's going to be more aligned with who's in right now. And I think one of the things was they mandated certain benefits that you had to have, and they're still sort of struggling with, do you have a package, do you have a streamlined or cut down version of that? How many in here have a high deductible health plan as your coverage? Only a couple. It's moved more and more toward that direction, and probably will in the future. So you have a lot of individuals now that have to meet a family deductible or an individual deductible, and it's it can be a couple $1,000s, it can be up to $10,000, or even higher for a family. Most people don't have that in savings. And so there's that individual component of it and what's driving and how they make decisions. And then if they're showing up and getting services and can't pay at the doctor's office or the hospital, that's another component. I think the really hard thing in the future is going to be that the services that you can't get anywhere else but in a hospital, the emergency, the intensive care units, the burn units, those don't pay for themselves by the patients that are in them. And we've done this cost shifting over the years between commercial people that are covered by commercial insurance pay 30 to 40% more just to subsidize where you fall short on Medicaid or Medicare. And those units are, you're putting off those expenses in other things. Well, as a lot of those services move outside of the hospital, it makes it harder and harder to maintain the things that only can be done there. And Texas has this thing that we don't see in a lot of other states yet, but they're everywhere, are these freestanding ERs. Right. And they're just, I don't know about your city, but where I live in Dallas, I have 3 of them within a couple miles of my house. And people are showing up there thinking they're urgent care and they're getting charged an emergency room visit. And so I'm not sure exactly what's all driving that in this state, but that's another area where you've got a high-cost venue that's sitting out there that's really not necessarily probably the most cost-effective way of delivering care.
But let's talk about boards, because we've been talking about all the different shifts and all the impacts. But how should healthcare organization boards address these challenges as it relates to their own systems?
One of the things, I went on a board in 2005 in New Mexico, and Presbyterian had like a competency wheel that they used, and they wanted certain competencies on their boards. And I think that's one of the things that helped that board expand out and do what they were doing. And so I think one of the things is going to be looking at what's the composition of the board, what type of people do you have on it, what are you driving it. Healthcare is such a complicated industry that it's always a challenge for people that are non-healthcare that sit on healthcare boards. Are there anybody here that's on a healthcare board? There's a couple of you. Okay. Yeah, so one of the things is just keeping up with what's going on in the industry when you have a day job that you're doing as well. And so I think one of the challenges for governance in healthcare is how do you provide that education? How do you lay out the challenges that particular organization is having in context of everything that's happening in the industry? And then where are you taking that so you can ask good questions and then make the right decisions for the organization?
So in the current environment, and things are changing so rapidly, can you just sort of give an example? For instance, if you happen to be on like the United Healthcare Board, and with the things that they're contemplating changing, or for that matter, a better example would be the Aetna CVS, because Aetna is in one space, and then you have retail pharmacy, and you have a board that's already in place, and then the CVS board is coming in. So on those boards, what do you think, how do you deal with the amount of change that is taking place?
I think for a lot of those, you've got different cultures of organizations, and you've got different footprints of what they do. And so I think the boards, part of the challenge is going to be is strategically, how do you bring that alignment, and how do you bring opportunities to enhance both those businesses by coming together to be stronger than they would be individually? And what are some of the challenges that go with that? So when you take something like an Aetna CVS, I mean, CVS has a PBM through Caremark that handles their pharmacy benefit management. And so they've had a lot of experience within healthcare, but then how do they take that and combine it with an insurance company? And where do those fit together and where do they not? They don't probably have some duplication in some of the executive knowledge levels, and some they do, but really laying out what's that combined entity look like, and then how do we migrate from where we are to go there forward.
So Craig, I mean, you have in your system how many different boards?
For me, I have one parent board, and then I have another local board for Seton, and then one for Providence.
So any of these topics, are they being discussed?
I think it's completely relevant. I think for us, it's, very specific example. Historically, you looked at market share to determine how well you were doing. That's an inpatient measure. As more and more of that business moves to the outpatient, the whole measure of market share is less relevant. If you really believe that we're going to move towards, kind of chips all in towards value-based management and or this ambulatory space, do you really need to go buy another hospital somewhere and expand, or spend $20 million more on hospital expansion? Or do you take that $20 million and go stand up 5 urgent care practices or imaging or whatever the case may be? Those are real practical examples. Do you shed assets and redeploy that in some other way? Hospital right now, I might be off a little bit, but this is pretty close. If you were to build a new hospital from scratch today, all in, it's about $1.2 million per bed. That is a huge amount of capital and fixed cost. I mean, I just left Houston in September to join this organization. A year before I left, we launched a $650 million expansion project for a new bed tower.
Wow.
I mean, how do you, in the new world, how do you even pay for that? I mean, if ultimately everything's moving towards the outpatient side. So these are weighty decisions that, in my opinion, can either advance your health system or kill it or force a merger or an acquisition. I mean, because the stakes are that big right now. And there are a lot of, go back to your mergers and acquisitions. That's forcing some of this because people figuring they can't do it on their own, they need help.
So I have a question from the audience. As reimbursements get squeezed and costs go up, what is occurring with patient outcomes? And
Sorry, what was that part? What was that about the outpatient outcomes?
Yeah, what is occurring with patient outcomes? And then added to that, are patient outcomes an agenda item at the board level?
Well, they certainly are in the health plan space because you'll hear about star ratings, you'll hear about risk adjustment, and so what CMS is measuring, especially in the Medicare Advantage plans, and some states are doing this as well, is are the right types of preventive measures being taken, is the right type of care. There'll be certain measures, HEDIS is one that they often will refer to. So if you're a diabetic, are you getting an eye exam, are you getting a foot exam, are you having a controlled A1C level, but different things that are measuring because you're trying to improve the outcome of the care of the patient. And how that translates from the health plan and the delivery system is that in order to meet those, if you're a 4-star or above, you get additional reimbursement, and then that then flows down to the providers. If you aren't reading those quality metrics, then you get less to deal with, and that may also translate into benefits for the beneficiaries. So there really is a focus, I think, at the federal level in evaluating the care that's being given, especially to seniors, about are they meeting those quality metrics, and more of that is shifting to outcome measures and less of process measures. So that's still embedded in there, but it really hasn't necessarily translated, I don't think, to the commercial coverage yet, and it's a state-by-state issue on Medicaid.
So let me ask you, John, at the Texas Hospital Association, you were with hospital execs. What things at the board level are that's keeping them up at night?
Well, again, I think the most important thing, and Shirley Robinson, who runs our Texas Healthcare Trustees, is here as my guest, is just, first of all, explaining to the board how important advocacy is to their job, particularly in the healthcare space, because it's probably one of the most highly regulated industries, either from the regulation licensure side or from the payment side. So just explain to them that it is an important part of your role. It's an important part of your role in the community, particularly when you're looking at, one of the things we haven't talked about is behavioral health. That's another area where when you look at hospital readmissions or inappropriate ER usage, a lot of times it's because we don't have enough behavioral health capacity in our community. And so a lot of these partnerships or investments, it's almost better for you to invest in behavioral health than doing some of the inpatient stuff, because that's going to help everyone. So I've heard Shirley talk before about having those boards reach out to some of those other community organizations as well to build those relationships, whether it's home health, nursing home care, or folks that are in the behavioral health space. So again, I think what keeps people up at night is what Craig said, is having a foot on the in the boat and one on the pier at the same time when you know the boat is leaving, but you still have these legacy payment systems, legacy regulations, and legacy hospital campuses that you've built. So
one other question, and then we'll see if we have further questions from the audience. The issue of direct to consumer. Disney has on-site campuses, and they are working directly with the health system. PepsiCo is doing the same thing. So you're seeing this shift of larger employers going directly to the health system and designing for their employee benefits. How do you see that impacting us here in Texas? Do you see that as something to come, or?
Yeah, I would say yes, absolutely. I think that that is an emerging trend. I mean, there's a lot of dollars in the healthcare spend that are tied up in health plan and administrative. I mean, no offense, I've got two health plan people here, but that's just the reality. And so companies are seeing the toll it's taking of the total expense and the premiums that their employees are paying. They've gone up 221% from 1999 to 2015, and inflation's gone up 42% during that time. So the burden on the employees is real. And so one of the to-dos for organizations is they look at that and not disrupt the plan design, which could impact their employees adversely. They'll go direct to the health system. And so I think you're going to see more emergence of that. There's a lot of discussion around that. And just a two-second example, my prior organization, we had that with Walmart. And so we were a regional destination for spine care for Walmart. And so a Walmart employee had a spine injury, it was cheaper for them to put them on a plane and fly them and their spouse, if need be, or significant other, to Houston for our pathway and our protocol and our clinical care, and then send that patient back. That was one sliver of healthcare. I mean, it's hard to do that for everything, but you're seeing organizations pick regional destinations of high-end services that produce really good outcomes at lower cost.
So, question from the audience, given the challenges you've been describing, what percentage of the board's time is devoted to strategy?
Probably not as much as it should be. We had a discussion in a session that I was in around how much of it's insight and how much of it's oversight. And I would put the strategy in sort of the insight piece of it and really looking at it. And so one of the boards I was on, we actually redesigned it. And what we found is that if you have an agenda and you spend most of your time either in getting presentations or covering routine types of issues, that's probably not the most effective use in the strategy. So with this particular Board of Presbyterian, what we said is that we want to have a strategic discussion at each of the meetings. And so we set aside the first 2 to 3 hours to have that strategic discussion, and then followed it with things that could be done on consent agenda or on board portals or whatever, and push some of that off. I think the biggest challenge for management in working with boards is, are they presenting the information in a way that you can have those discussions? You read it in advance, you have some of the questions maybe even posed that you want to discuss, and you build the time into the agenda to have that type of discussion. Often what you get is presentations to you and not necessarily the time to really have those strategic discussions. And then what do you want from the board in the strategic alignment? So it's management's responsibility to carry out the tactics and that on the strategic plan, but how do you elevate to the board level to set that direction? And when you change it, how do you bring them in to help make sure that you're making the appropriate changes?
Yeah, at THA, we've got a fairly large board because we're trying to capture the diversity of the industry, urban, rural, all the different classes of hospitals. And one of the things, we've actually tried to carve out more time for strategic discussion, and have found it helps to break into small groups, give those groups different questions, facilitate discussions, and then come back and report to the group, because folks kind of talk better in some of those. So I agree. It's you kind of get to where you want to process through that, but we found those strategic discussions to work pretty well, especially going into a legislative session when you're trying to wargame a lot of these things.
Craig, did you have anything to add to?
Again, I've been through 3 board meetings in my new organization, but we typically will tee up a dinner discussion the night before. It is a presentation, but it kind of spurs some thought and some dialogue. And then I think we do a pretty good job of having consent agenda items, and then I spend time at the tail end of the board meeting usually teeing up either a particular topic, or I've presented our aspects of strategic priorities. I'll be presenting our strategic plan at the next board meeting. I think we're moving more towards that. I need counsel and guidance to help us make some tough decisions. I'm very much inclusive in that regard. We don't have it all figured out, so we need to be able to have meaningful, objective dialogue and make important decisions.
Okay. So last question. We have the Dell Medical School here in town, and we're all excited about that. They have a slogan that says "Rethink Care."
Right.
So what does that mean in the context of our discussion today? Can you kind of?
Sure. Yeah. Dell Medical School, great addition here. They're our academic partner, so we have an academic affiliation with the Dell Medical School. So you're going to see Seton and Dell Medical School for the next 23 years in this community for sure, and probably another 25 after that. But they have completely have the entire approach of rethinking healthcare. And the resident education model is not the same resident education as traditional medical schools. The medical school education is not the same. Typical medical school education is 2 years of clinical study in the classroom, and then 2 years after, your last 2 years, you're actually doing true clinical rotations. They start that up front at Dell Medical School. Those medical students are invited and participate in these discussions around value-based healthcare and finding ways to deliver healthcare at a lower cost. And then 2 other elements that I think are really important. They started the Healthcare Design Institute, and if you know of the company called IDEO, it's IDEO. They brought in Stacy Chang, who was an executive for IDEO, full-time faculty at the University of Texas under Healthcare Design Institute, and their sole job is to innovate healthcare delivery, patient flow, what the practices look like. So all of that design work is going on, and then the other element is there's 2 people through the Harvard Business School that are very well known in healthcare around value-based care and how things are designed. It's Michael Porter and Elizabeth Teisberg. Elizabeth Teisberg is full-time faculty at University of Texas, Dell Medical School. And so her sole job is working around value-based and population management. And so I'm literally yesterday talking to the dean of the medical school around a project we want to work on in women's healthcare that is unlike probably 95% of the discussions taking place in the country, because it's thinking ahead around value-based care and finding a way to be a destination either by large employers, as we talked about, or payers for high-quality, lower-cost care, but design that in a very different delivery model. So it's pretty exciting.
Good. So let's wrap up. The title is Lessons Learned from Healthcare. What are some of the key takeaways, and maybe we just do one each, that we can leave with the audience? John?
In healthcare, it's Craig said it earlier. Whether you like it or not, the government controls what you do, either on the regulatory side or on the payment side, and it's not fun to deal with those folks a lot of times. But if you're not at the table, you're probably on the menu. So stay plugged in.
All right, Kathy.
I think about how much you do on your smartphone that you used to either not do or do at a computer or do someplace else. And I think a lot of your healthcare is going to be centered around how you use that device. And so rethinking how information gets to the consumer, how they use it, how they schedule it. And there's a lot of influence that's going to have on both the payers and the providers of care.
Okay, Craig?
I'd just end by saying that clearly we're in an amazing amount of disruption right now in healthcare. And so as a board member in your own organization or an employee, an employer, recognizing this push and pull and this tug that's taking place in a very important component of our economy, but more importantly, an important component of our communities. And so even in the midst of all of this crazy change and uncertainty and the legislative hassles and trying to determine how to partner and work with health plans, there's a patient at the end of every single decision. And so we can't lose sight that even in the midst of all this unbelievable change, that how we deliver care and care for patients and families is why we do what we do. And so remembering that that is actually why we're here, I think is incredibly important.
Join me in thanking the panel for today's discussion.